Hello, everybody, and welcome to the Animal Heartbeat. My name is Kieran Bourget, and I am here with my brother in veterinary cardiology podcasting, Jose Matos. Today, we have a real fantastic episode coming up.
We have another great episode today. I know I say this every time, we have a great episode, but it's true. We have another great guest with us. We'll be talking about the RAAS system, the renin-angiotensin-aldosterone system. And we have with us today a top clinical researcher on this area, Dr. Marisa Ames. Marisa is an associate professor of veterinary cardiology at UC Davis, California, and her research focus is on the RAAS system and management of heart failure. Marisa has published many milestone papers that have helped us or allowed us to better understand the RAAS system in dogs. Welcome, Marisa. Thank you very much for joining us today.
Thank you. It's an absolute pleasure to be here. And I just have to say, I'm really thrilled that there are more veterinarians in podcasting. So thank you for that.
Thank you.
I'm not sure if it's a positive contribution. That remains to be seen. But thanks so much for joining us. It's great to have you here. Imagine, if you will, that I'm a cardiologist who has not kept up to date on the RAAS and the research that's out there. Obviously, I'm all over it, but imagine I'm not. How would you explain to me the importance of the RAAS as a cardiologist to approaching our patients?
There's a lot of curiosity around RAAS right now. And of course, it is important in just our day-to-day existence in terms of maintaining blood pressure, homeostasis, and fluid and electrolyte balance. So important literally day-to-day when we don't actually think about it. But unfortunately, in chronic cardiovascular, kidney, and even other diseases like gastrointestinal disease and maybe even cancer, it becomes maladapted or dysregulated. And excess production of especially certain hormones like angiotensin 2 and aldosterone end up contributing to the chronic remodeling and progression of these diseases. So I think as a cardiologist, it's obviously very important in cardiovascular disease, but we're also learning where it plays a role in other diseases like gastrointestinal and cancer.
What I think is very cool about the RAAS is when we studied at vet school, was a very simple one little diagram in a textbook with 2-3 enzymes, 3 peptides.
We all learned that.
And that's
it was a good answer for an exam question. Easy stuff, right?
Exactly. It reminds me like the coagulation system. Everything was very basic and simple. And now, boom. When we read your papers, we understand the huge web, complex system that the RAAS is. And one of the things I like is that there is now kind of a good RAAS and the bad RAAS. Can you tell us more about that? What is the classical and versus the alternative RAAS, and why would this be important then when we try to inhibit the RAAS system?
That's a great question. And we all learned mostly the classical RAAS. So when we talk about classical RAAS, we talk about the angiotensinogen pathway to angiotensin 1, 2, and its major secretagogue aldosterone. So we usually talk about that pathway, which is the more vasoconstrictive, sodium and water retentive pathway, and the pathway that was first discovered. And now we're learning that there's counterbalancing pathways, and most of this is through the metabolism of angiotensin 1 and 2 into other metabolites. So angiotensin 1 and 2 can be metabolized into angiotensin 3 and 4, which are more aligned with the classical RAAS and vasoconstrictive, profibrotic, sodium and water retentive peptides. But it can also be transformed, angiotensin 1 and 2 can also be transformed into other peptides that have counter-regulatory actions. And this is mainly angiotensin 1,7 and angiotensin 1,5. And it's really 1,7 that is probably the most beneficial counter-regulatory peptide. It's vasodilatory, antifibrotic, antiproliferative, and works via its MAS, that's the MAS receptor, to do most of this counter-regulation. And really how the overall system is balanced, whether it's classical versus what's called alternative RAAS, which is the angiotensin-1,7 and mast receptor arm. Really what determines that overall balance is going to be the activity of the enzymes. So there's all the enzymes that metabolize angiotensins, of course, ACE being the most important in the classical system, and ACE2, neprilysin, being more important in the alternative system, shunting the pathway over towards alternative. And we're learning a lot about the circulating balance of this system, and we're not even sure yet what the best profile is. But yes, it is a very complex web. We often call it good versus bad, and that may be a little bit too reductive. It's
Right.
Probably best to think of classical versus alternative.
So classical is the stuff we learned at vet school. This is the
Exactly.
more vasoconstrictive side, the profibrotic side. The alternative is the more recent understanding, and it's more vasodilatory antifibrotic, but it's the balance that's important rather than one way or the other. Is that right?
Yeah.
Okay.
Yeah, that's a great summary.
So the literature over the last 5-10 years has expanded massively on our understanding of the RAAS in dogs and cats.
Yeah, there's been an explosion of RAAS research in the last 5 years. And if you just do a PubMed search, it's approximately 2 times the amount of work in the last 5 years as compared to the preceding 5 years. That's so exciting. And like so many things in cardiology, where you start learning a little bit and then you realize how extraordinarily deep and complicated it is. And literally science is happening all the time that's just advancing our understanding even further. So something I thought I understood a year ago, I realize is actually, more complicated or maybe even incorrect. So this phenomenal explosion of RAAS research has taken place, I think motivation from our mentors, but also improved ability to quantify the renin-angiotensin system.
Okay.
And so that would be easier assays. This is a hormone system that is labile. These peptides are quickly metabolized once the blood sample is taken. So protease inhibition is usually the historic way to measure these, where you immediately protease inhibit a sample. And that is cumbersome and difficult, especially with animal clinical research. And so improved methodologies have come into play to how we assay these. A business in Austria has developed only to measure the renin-angiotensin system because it's just so difficult and people have struggled for so long. So the group in Austria, Vienna, they developed assays that basically can overcome the protease inhibition problem. Anyway, this is extremely long-winded. I apologize, but
no, but
it was such a pain in the butt to measure RAAS earlier that it's just so much better now. And so that, I think, contributed to the explosion.
So it's more accessible to do it, and we believe the results more.
Exactly. And the whole comprehensive tree kind of helps corroborate, you're getting the whole tree, many of the angiotensin peptides as opposed to just one.
When we read all those papers about how you quantify the RAAS and so on, what I always struggle with is the RAAS is affected by so many different things: hydration status, the dietary sort of intake, the time the sample was taken in relation to the pet's meal, and so many different week-to-week variation, which you have shown as well. How do you take that into consideration when we quantify the RAAS? How you take all these different variables into consideration that might have affect your result?
Yes, and I think that's important to acknowledge is there is, in terms of circulating equilibrium concentrations of RAAS, there is what we studied was week-to-week variation, but of course there's probably also day-to-day and even minute-to-minute based on what you just said, based on influence of stress and whatnot. And Dr. Hammond and I looked at that variability and found that on average, the circulating equilibrium concentrations from week to week, the variability of the directly measured angiotensin peptides exceed the coefficient of variation for the assay. So there's meaningful variation that I think makes us question the utility of just a spot check for that one animal. However, when you look at ratios, that is we have several ratios that show us the balance of RAS. And one of the ones we used was kind of more of an alternative ratio, meaning we take the alternative peptides like angiotensin 1.7 and 1.5, kind of the good guys, so to speak, and create a ratio of all peptides. So not just the Ang 1.7 and 1.5 good guys, but we also add in angiotensin 1 and 2. So it's sort of a ratio of good versus everybody. And that ratio actually had a coefficient of variation week to week that was actually less than the coefficient of variation of the assay. And so the balance of a person or animal's RAS is probably more stable and is something that we could use. And so that's one way to think about the RAS and try to average out some of these variations.
Just regarding quantification, we see a lot also in different papers the use of urinary aldosterone to creatinine ratio, which sounds like a smart, easy way potentially to assess what is happening with the RAS system. Is that useful? How much the urinary to aldosterone to creatinine ratio tell us?
A lot of us wanted that to be useful. It would just be so easy if an owner could take a urine sample, bring it into the clinic, boom, you have a wonderful point of care biomarker. But I think the concept, it came from the great minds, that I think a lot of people looked at it. Dr. Atkins, of course, at NC State, and Dr. Simon Elliott over in the UK, trying to study cat RAS and realizing that urine aldosterone in cats is not easy. So I think a lot of us wanted it to be a useful biomarker. And unfortunately, the sort of the day-to-day variability that we found in dogs, this was a recent proteinuria study with Dr. Shelley Vaden at NC State. There's just a lot of day-to-day variability in healthy dogs. Hasn't even been evaluated in dogs with actual cardiovascular or kidney disease. The day-to-day variability just makes it not a useful point of care biomarker. Potentially, it does often correlate with various indices of RAS activation and classical RAS activation. So it probably gives an idea of the animal's RAS profile in a very non-invasive, easy to collect way, but it unfortunately probably isn't the best. We used it as our definition for aldosterone breakthrough. We found there has been very consistent reports, not just from, the NC State research, but, a lot of researchers have used aldosterone urine aldosterone creatinine ratio to study aldosterone breakthrough and have come up with very consistent values. I mean, it seems like on average, dogs with cardiovascular kidney disease, it's about 30% have aldosterone breakthrough based on the urine aldosterone creatinine. So that consistency across several studies does argue that it's probably giving us some idea of what is happening with the global RAS in these dogs.
It's super interesting. I just want to back up the truck a little bit. Tell us about aldosterone breakthrough. And for those of us who are rusty in the RAS, like myself, what's the difference between aldosterone breakthrough and aldosterone escape?
Great question. And it's the same, aldosterone breakthrough, and it just depends on what you chose as your
it's
name.
Terminology.
Total terminology.
Fine. And
aldosterone breakthrough or aldosterone escape is simply an increase in blood aldosterone concentration or urinary aldosterone concentration in the face of ACE inhibitor or ARB administration. So theoretically, ACE inhibitor by reducing production of angiotensin 2 and the ARB via blocking what angiotensin 2 does at its type 1 receptor, theoretically, those should reduce secretion of aldosterone from the adrenal gland. And you would expect, if all is working well, that you have a reduction in aldosterone after starting those drugs. And aldosterone breakthrough is simply the phenomenon either increasing or even high aldosterone. And so that's sort of been argued as, the two are better in combination. So an ACE inhibitor or an ARB should be paired with something like spironolactone to block the mineralocorticoid receptor. And there is small data.
That makes sense if 1 in 3 dogs is experiencing this when we're treating them, trying to reduce the effect of aldosterone.
Exactly. And it does seem there's small data, and this is again that proteinuria study with Dr. Shelley Vaden and Atkins and myself, and it looks like aldosterone breakthrough based on the urine aldosterone to creatinine ratio happens with ARB and an ACE inhibitor. So it doesn't seem like the ARB is a magical solution to aldosterone breakthrough.
So how long does it take for that breakthrough or escape to happen?
It's a little bit anecdotal in terms of observations we've made based on short-term pharmacologic RAAS activation models, as well as just looking at clinical patients with chronic kidney disease and proteinuria or actual heart disease. And it seems like it can happen very quickly. So in the pharmacologic modeling, happen within days, whereas in the more chronic long-term, you can see a variety, days and even weeks. So it's hard to predict when or if it'll happen in an individual patient when we haven't determined the risk factors as to how you can predict whether that will happen. And as you mentioned, with a third being a pretty consistent finding, a third of animals experiencing aldosterone breakthrough when receiving an ARB or ACE inhibitor, it's just been simplified to the rationale of combining ACE inhibitor with spironolactone, which the best trial looking at benazepril paired with spironolactone in myxomatous mitral valve disease and heart failure, that at least is helpful in terms of supporting this theory with an actual outcome study.
So we already realizing how complex the RAAS system is, and it's not only the alternative, the classic traditional pathway. You also have an alternative pathway, and so on. And then, just to make things more complicated, you have mentioning about the circulation, the circulatory RAAS, but there's also a RAAS at the tissue level, right? We may also have a RAAS operating in the myocardium, for example. How do we even quantify tissue RAAS, and how can our drugs affect tissue RAAS, and so on?
Yes, and that's an ongoing area of research is to understand the connection between the two. So they are regulated separately from one another. And so when we think of the circulating RAAS, we think of the hormone system in the bloodstream. So angiotensinogen constitutively produced by the liver, always available, and the rate limiting enzyme being released from the juxtaglomerular apparatus of renin. And that basically triggers this cascade within the bloodstream and the formation of angiotensin-1, which is, of course, then metabolized via all the ACE and other aminopeptidases into its various other angiotensin metabolites. And those are within the circulation. And of course, angiotensin-2 being the major effector molecule in circulation, causing the effects in circulation, which is, of course, most importantly, vasoconstriction. That is the kind of the circulating RAAS that we all think of first when we think of the renin-angiotensin system, and that is what's easiest to measure. But the tissues also have their own, the same enzymes within the tissue. And so the current understanding is that angiotensin-1 from the circulation is primarily feeding the tissues, so to speak. So Ang1 from circulation is within the tissues, then metabolized to classical and alternative RAAS peptides based on the enzyme construct within the tissue. And of course, the tissues are where the receptors are. And so the tissue is kind of where the rubber hits the road in terms of the angiotensin system. But the tissue, it's very difficult to measure angiotensins in the tissue. It's present in femtomolar, so 10 to the negative 15 concentrations, like the typical angiotensin peptides, as compared to the circulation, which is actually not much greater, but it's picomolar concentrations. And so circulating RAAS, we're so excited. We're much better at measuring that comprehensively. And so now tissue RAAS, people have been working on measuring the tissue RAAS. And if you do open heart surgery or constantly do renal biopsies, you're golden. You're great. You can basically flash freeze
the tissue samples.
Exactly. So you get the fresh tissue. That is the only way to directly measure angiotensin peptides is fresh tissue from beating heart, perfusing kidney, flash frozen.
Do the concentration in the circulation reflect the tissue RAAS or not necessarily? So can we, when we read the trials and the studies on circulation RAAS, Is it likely that this is reflecting what is happening at the tissue level or not necessarily?
That has been corroborated in human studies of renal transplantation and heart transplantation. So in terms of there's correlation between the tissue angiotensin peptide concentrations and circulation. And similarly, the degree of dysregulation of RAS in the tissues is correlated to both kidney disease or kidney remodeling and heart remodeling in people. And this comes back to Jose's question, which is a good one, is kind of if tissue is where the rubber hits the road in terms of the bad actors of chronic RAS activation, it would be nice to know what our drug effects are in the tissue. Yes, we've got a lot of data understanding the circulating RAS, but basically those circulating peptides, the effect they're going to have is basically how they interact with their receptors and enzymes in the tissue. Current research is trying to overcome this, and we're basically currently collecting fresh samples from laboratory research animals. So we have heartworm research going on at Georgia that the folks there have been willing to immediately extirpate tissues post euthanasia. Similarly, HCM colony cats that are immediately euthanized and immediate extirpation. So in these very special research colonies, we're basically getting some tissues from these research groups that are unrelated to their studies, but we're getting some fresh tissues that are allowing us to understand the rapid degradation rates of angiotensin peptides. It's probably within 10 minutes.
Wow.
But the enzymes remain active for hours. And so you can actually use the tissue to understand what the enzyme milieu is in the tissue via experiments where, say, you put homogenized tissue just alone, and if you feed it with angiotensin 1, that tissue will make angiotensin 2 because of the enzymes that are present. You can use an ACE inhibitor and see what's left. You can then use an ACE inhibitor plus a chimease inhibitor and see what's left. Or you can use a chimease inhibitor and see what's left. So you can basically kind of understand, is ACE the big enzyme in the tissue or chimease? And so that's currently where we are with our tissue research, is understanding what are the actual enzyme activities in the tissue. And of course, the end goal would be to find some sustainable way where we could get a clinical sample and actually understand, what the differences are in our drug therapy at the tissue level to see if we're actually making a difference. And of course, with all of this RAS research, I think what we really need is we're learning kind of what the profiles look like in diseases with drugs. Hopefully, we'll learn more about what the tissue looks like with drug therapy and in various diseases, but we need some more outcome trials to better understand what is the ideal RAS peptide and how could we use this as a biomarker in the future. And so outcome trials are probably what's going to be hopefully the next step, using both tissue and circulating RAS.
I think that will be really interesting because it will bring this sort of more basic science, if you like, back into the clinic. That brings us, I think, on to thinking about treatment. Obviously, our understanding of the RAS is massively important, and the potential for biomarkers and using the measurement of the RAS to decide about, do we treat, do we not treat at this point, or what's the prognosis, or potentially make a diagnosis, I guess. That's attractive. But if we think about using these to understand the benefit of treatment or the potential benefit of treatment, where are we at with our understanding of RAS inhibition, or at least inhibiting the bad side of the RAS, the classical side of the RAS activation? What stage should we be thinking about treating these patients with ACE inhibitors and or spironolactone?
I think fortunately, the large clinical trials, with the BEST trial especially, have helped us understand that at least in myxomatous mitral valve disease, heart failure, in dogs with myxomatous mitral valve disease and heart failure, the dual inhibition of RAS with ACE inhibitor and spironolactone improved outcomes. So at least we have some outcome data to rationalize the ACE inhibitor and spironolactone as part of our quadruple therapy with furosemide and ivabradine. And of course, that gets extrapolated to many heart diseases in the dog, probably for better. and not for worse. So that's probably a good thing. So I think in terms of other stages of disease, I think we're learning more about the RAS profiles in the heterogeneous B2 stage. On average, with that one study with Dr. Hammond and myself, we didn't find significant RAS activation in the B2 stage as compared to normal dogs. But their RAS is changing. So they're having sort of a shift in the balance of RAS, and they're starting to have higher levels of, or higher balance of alternatives. So interestingly, they seem to have increased angiotensin 1.7 and 1.5 as compared to the other peptides. Part of that study, we looked at an ACE2 surrogate, and that's basically a surrogate measurement from the angiotensin peptide tree, or a surrogate of enzyme activity, since the comprehensive RAS profiles are not measuring the actual enzyme activity. They're just getting the angiotensin peptide concentrations. You can create surrogates for enzyme activity, and one of them is ACE2, to understand kind of the most beneficial enzyme of the alternative system and how is that changing over time. And so what Hillary showed in her paper looking at myxomatous mitral valve disease and RAS profiles is that the ACE2 surrogate seems to increase in the B2 dogs as compared to healthy dogs. And I think in that B2 stage, the increase in ACE2 is compelling.
You mentioned before aldosterone breakthrough, and we have data now showing that spironolactone and benazepril are useful in stage C, and there's also different trials on stage B and asymptomatic disease. A common question argument is, what is the right dose for an ACE inhibitor or spironolactone, and does dose matter?
This is a great question, and I think Dr. Ward and Moschel have done the best work to try to understand, does dose matter with especially ACE inhibitor, and they've studied the ACE inhibitor benazepril, and using time-weighted averages of angiotensin peptide profiles to better understand how these different dosages, so I think it was 0.125 all the way up to 0.5 mg per kg dose. They studied dosages to determine the effect of different dosages on time-weighted averages of angiotensin peptides over 12 hours. And there is a more beneficial shift in the angiotensin peptide cascade with the higher dosage of 0.5 mg per kg orally twice daily as compared to 0.125. So you have a greater reduction in the classical RAS peptides. And so they've shown that, yes, there's a beneficial shift in RAS that is the most significant change at the higher dosage of 0.5 mg per kg orally twice daily, which is not what's been historically used in studies, especially in preclinical disease, such as the DELAY trial, or some of the earlier ACE inhibitor trials using, enalapril, so a different ACE inhibitor. And so that has brought into question whether we should have been using, much higher dosages, such as 0.5 mg per kg twice a day for both benazepril and enalapril. And so that comes back to that concept that, yes, the higher dosage leads to a better angiotensin peptide profile, but basically what these angiotensin peptides are doing at their receptors in the tissues is actually what matters for outcome. So it's food for thought that we would, if we're designing a ACE inhibitor or other RAS blocker trial, studies like what Dr. Ward and Moschel are doing at Iowa can help us understand what the best dose is for the RAS profile and our best guess as to what the best RAS profile would be. And we should use those studies to rationalize dosages for future RAS modulation studies. But I think back to the original question of, where are we with RAS inhibition? Clear evidence in stage C, no supportive evidence in earlier stages, at least for myxomatous mitral valve disease in the B2 stage. Yes, dosage might matter, and maybe if we were to repeat some of these trials with higher dosages, we'd actually see a benefit. But I think the future is going to be more modulation of the renin-angiotensin system, which is not just simple blockade. And a lot of interesting work has been done by the group at UPenn, led by Dr. Oyama, where they're studying, what does an ACE inhibitor do to the circulating RAS versus an ARB. They
That's
both
really
lead
interesting,
to
isn't it?
Yeah, they lead to these expected changes where, of course, an ACE inhibitor is going to increase levels of angiotensin 1 substrate, and that gets metabolized in the dog. And, we can learn what the balance, do they generally go to one angiotensin 3 and 4 in the more classical side, or does that excess Ang1 go to the 1,7,1,5, alternative pathway? And the dogs seem to be good at shunting down the alternative pathway. And so ACE inhibitors tend to change the pathway in that way, whereas ARB leads to an excess of Ang2, similarly of substrate for further RAS metabolism. And on average, dogs tend to shunt in the good direction with generation of 1,7 and 1,5. But what Dr. Oyama and his group did was then in vitro or ex vivo, taking the blood sample out of the dog, they then added ACE2 and said, okay, we're going to take it one step further and not only increase substrate, which fortunately seems to kind of enhance good RAS activation, we're going to also add the enzyme that is the major enzyme that shunts things down this pathway. So add ACE2 and further amplify. And so ARBs appear to be somewhat better than ACE inhibitor in amplifying that good RAS pathway. And so that sort of modulation combination of ARB plus exogenous ACE2 is probably worth looking into. And I know the group at UPenn is interested in that because ACE2, of course, is a protein drug. So you have to give it parenterally, and that's not easy. So they're looking into how can you deliver ACE2 orally? And that's leading to some really interesting research that involves lettuce, like plant encapsulation of the ACE2.
Amazing.
That's very cool that we are not anymore just trying to block one of the pathways with a drug that we thought in the past magically would just kill the system. And I think it's incredibly clever that we try to modulate and shift the system to the good guys. I think that's very, very cool.
It's such a nuanced system, isn't it? That modulation rather than just blockade makes sense. That we can try and push them down the beneficial pathways rather than just blocking them and going, that'll be fine.
Exactly. And I think our new understanding and our ability to study the system being so much better, we can hopefully a priori decide in smaller studies like what combinations make the best RAS profiles, and then bring that to testing in an outcome trial and actually confirm that, yes, this is actually a better treatment.
You mentioned angiotensin receptor blockers with the work from Dr. Oyama. We have a licensed angiotensin receptor blocker for cats, telmisartan, for cats with systemic hypertension, dogs with systemic hypertension. There's data on proteinuria in dogs and so on. Is there any data of the use of telmisartan in dogs with heart disease or in cats with heart disease?
To my knowledge, there's no actual outcome trial regarding an ARB or a trial comparing ACE inhibitor ARB in heart disease. But as you mentioned, yes, in proteinuria, some very compelling results in the dog. And I think that ARB, based on Dr. Oyama's data, does seem to have a more beneficial shift in the RAS profile. And so you could argue that it may be better for long-term outcome. So the data that I'm aware of is Dr. Oyama's data to kind of understand what the ARB does to the renin-angiotensin system and comparing it to an ACE inhibitor. But I think listeners out there may know of some, BI has a trial in the works, but as far as I know, compelling data to support ARB use, but we don't have any trials at the moment. And I think that would be very interesting.
Absolutely. Kieran mentioned before biomarkers, and we always have a question about biomarkers in each episode. And would be very cool to have a biomarker to know, is there more the alternative versus the classic pathway activated, or is there aldosterone breakthrough to do more of a personalized medicine and to go, okay, in this patient, let's try to favor the classic versus the traditional, and is there aldosterone breakthrough or no? Do you think that will happen in the near future, where we can have a RAAS biomarker, point of care biomarker, to better understand how good are we at blocking the RAAS system in a certain patient?
I think ACE2 is a compelling biomarker, and that can be measured via just more typical assays such as ELISA. And so ACE2 is being studied as a biomarker in people. So this is that good enzyme. And what's interesting about ACE2 in people is it does seem to correlate with cardiovascular outcomes. And it gained a lot of interest during COVID. It's obviously the receptor for COVID and what gives COVID access to the cell. But of course, it does much more than just let COVID in. And so there's been a huge explosion of research into ACE2, building on what we've already known of ACE2. And it is responsible for mitigating the effects of angiotensin 2 in the tissue. So it metabolizes angiotensin 2 into 1,7. And so it's really important in reduction of angiotensin 2 levels in the tissue. And so ACE2 being bound by COVID, of course, is not a good thing because it lets the cell in, or it lets the virus into the cell, of course, but it also, by binding and taking up ACE2, it is no longer able to provide its mitigating effect, decreasing angiotensin 2. And so that's been part of the cardiovascular consequences of COVID, is probably mediated by that occupation of ACE2. And how it becomes potentially a meaningful biomarker is that one theory is that during cardiac disease, ACE2 is actually cleaved from the tissue by angiotensin 2. So they sort of antagonize each other. ACE2 metabolizes angiotensin 2, but angiotensin 2 via the TACE enzyme is able to activate the cleavage of ACE2. So ACE2 leaves the tissue where it's actually providing the beneficial benefit and enters circulation. And so, coming back to our study with myxomatous mitral valve disease and in the B2 stage, why are we finding higher surrogate ACE2 levels? It seems like that would be a good thing. The RAS is shifting in a good way in the circulation. But what that probably is indicating is if this theory is true, and that with progressing disease, you have more ACE2 cleaved from the tissue entering circulation, that ACE2 is actually a biomarker that increases with progression of disease. And so it's a little counterintuitive.
So it's a marker of damage. What it does is good,
exactly.
But when you find it, it's a marker of damage. It's troponin I, isn't it?
Yeah.
We all have troponin I. That's good. I like it to stay where it is. But when it comes out and you can measure it, that's a bad thing. It shouldn't be free in circulation.
And whether it's going to be better than troponin I, or it'll be probably a different biomarker, and it'll probably
absolutely,
yeah, a biomarker of RAS, the RAS atmosphere in the tissue. And so I think if I had to pick one, I think ACE2 is probably a biomarker that holds promise. That's a lot easier to measure than getting a comprehensive profile. You could just use an ELISA type technology to get ACE2.
Yeah. There's this whole controversy about when to start RAS blockade. And there are certainly people out there who will say, if I see a dog in stage B2 and their left atrium has jumped significantly in 6 months on echo, I believe things are getting worse, and therefore I'll start an ACE inhibitor. Most of the people who promote that approach or follow that approach are from the US. And in Europe, most people tend to be quite conservative about waiting until clinical signs of stage C of heart failure before giving an ACE inhibitor. Obviously, it's not universally true, but it's an interesting difference of opinion. And it would be super interesting, wouldn't it, to be able to find a dog with B2 and test it and say, how badly is your RAS activated? And stratify risk in that way, because at the moment it's something that we can't do well. And obviously stage B2 covers a multitude of different types of dog in there. Just to say that their stage B2 is not enough, I don't think, to justify starting an ACE inhibitor. But of course, if they are bad B2 plus or whatever, then maybe
B3. Maybe you want a B3, Kieran.
I did not want a B3. B3 was
glad there was no
wasn't
B3.
It? I voted against a B3 strongly. We don't need more stages, but maybe we do need a biomarker there. And I feel conflicted saying that, because I think many practitioners, certainly in the UK, are very reliant on things like NT-proBNP, and they may start treatment based on NT-proBNP. And of course, most cardiologists wouldn't follow that approach. So sometimes I think, crikey, the last thing we need is another biomarker. But the question here would be very specific and something that we can't answer at the moment using alternative methods. I have a question about all of these good peptides we're talking about. Can we synthesize those and administer those as a drug? Is this something that would merit further attention? And perhaps there's a whole body of research out there. Where are we at with thoughts on that?
Yeah, this is actually a group at UPenn as well. So Dr. Oyama and his colleagues are very interested in, say, giving angiotensin-17. So why don't you just give the peptide that in circulation contributes to vasodilation and antifibrosis? And so I think there's a lot of interest in that as part of this whole modulation idea. And so why don't you give angiotensin-17 along with ACE2? And so just two ways to further amplify what's happening in the circulation. And again, though, that leads to the question of, what is this actually doing in the tissues, and how is it changing remodeling and overall outcome? So I think there's some interesting research that will hopefully come out of UPenn that's looking at administration of protein drug angiotensin-17 and ACE2, in combination with various RAAS inhibitors to see how different modulation schemes change the profiles in dogs. And that's all sort of the pre-work that's needed to understand what makes the better profile and what's something we want to bring to clinical trial. To come back to your point you just finished with, that B2 is so heterogeneous. There's some argument that early on in cardiac remodeling, and admittedly, this is mostly from models of acute chordal rupture and, acute mitral regurgitation, but there's some benefit to RAS activation in cardiovascular remodeling in basically helping the extracellular matrix of a remodeling heart. Does that matter for our patients with myxomatous mitral valve disease? Meaning, is it, should we not inhibit ACE in the very early stages? I don't know. Obviously, our dogs are not an acute cord rupture model, but because it is so heterogeneous, I think a more nuanced approach with, ideally assessment of their RAS, like using ACE2, maybe that'll be a more nuanced approach, because I think a lot of us do the same where, as their disease progresses, we'll think it's probably time to consider RAS modulation. And it's just all it confuses practitioners when we talk to them. It confuses the students, even our residents. So,
and we don't have a clear protocol for those cases, do we?
Exactly. Yeah.
You have some interesting data, Marisa, on looking at the effects of different diuretics on the RAS system. And I think that's relevant for our listeners because more and more people are giving torezimide. Torezimide is a stronger diuretic than furosemide. So one could wonder if will torezimide cause a more intense RAS activation? Does the RAS get more activated with torezimide versus furosemide? Can you please share with us your data when you compare? Is there a difference on RAS activation between furosemide and torezimide?
Yeah, that was a study from Bree Potter and me back in 2019. We were looking at equipotent, meaning similar urine production dosages of furosemide versus torsemide, sort of a very simple way to look at whether there's differences in RAS activation based on historical data that suggested there might be some anti-mineralocorticoid receptor activity of torsemide. So what we found was no, they both activate RAS to the similar degree, and pretty much a significant torsemide and furosemide and as loop diuretics are extremely potent activators of RAS, which has been borne out in studies of dogs in stage C. Once they're on furosemide, you can still interpret their RAS profile. It's very activated based on just loop diuretic administration. So no, it doesn't seem like torsemide is the more RAS sparing diuretic, at least in the short term in healthy dogs. Could that be different in the long term in dogs with sick kidneys? I don't know.
So that means that we still need RAS inhibition when we give torezimide, of course.
Yeah, the urinary sodium and potassium excretion profiles of the dogs in our study receiving furosemide and torsemide weren't different. It didn't suggest that torsemide was at least inhibiting the mineralocorticoid receptor in the kidney in our study. So no data yet to suggest you can stop RAS inhibition with torsemide. In fact, it's a very activated system with torsemide. So
of course,
you should keep on keeping on with the RAS inhibition.
You showed, I believe, that pimobendan does not activate the RAS, because one could argue may cause peripheral vasodilation, but you showed that pimobendan does not activate the RAS. But could pimobendan decrease RAS activation? If pimobendan increase renal perfusion, could it be? Is there any data looking at if pimobendan could decrease RAS activation potentially?
There are data looking at dogs that are on pimobendan, but not in an organized way to see if the initiation of pimobendan suppresses RAS, or if a group receiving pimobendan versus not receiving pimobendan are any different. So a lot of the RAS trials, pimobendan is just a background therapy and not studied directly. But theoretically, in general, RAS angiotensin peptides tend to mirror the left heart remodeling and progression of disease. So with some of the benefits seen with pimobendan, I would expect that there may be a subtle benefit in angiotensin profiles with the initiation of pimobendan.
So we've talked about trying to understand the RAS and where we're at. We talked about the effects of the old guard of treatment. What's next? What's the next generation of treatment that might be out there, or that's beginning to be of interest to veterinary cardiologists?
Yeah, I think there's pre-existing RAS medications such as Entresto, which is a neprilysin inhibitor, sacubitril, and valsartan, an angiotensin receptor blocker. Maybe not the best angiotensin receptor blocker for veterinary medicine,
Right.
but that's what's been created in people. So I think there's been some preliminary work. Danny Newhart at Auburn and others have looked and found, generally safe and well tolerated in animals. I think outcome data remains to be seen with something like Entresto, and it's a really interesting drug. It's a neprilysin inhibitor, and neprilysin is actually one of the beneficial peptides or enzymes, that shifts the RAS towards the alternative side. So it's interesting to think of why would you block that, but neprilysin is also an inhibitor of vasodilatory peptides, and so especially and natriuretic peptides. So inhibiting neprilysin is pro-vasodilatory and pro-natriuretic, and so on balance, the neprilysin inhibition seems to help in conjunction with the angiotensin 2 receptor blocker, and so it explains sort of the complexities of RAS when you look at these different drug combinations. So I think Entresto is interesting. I know currently it's been difficult to get a study started with Entresto just due to cost, unless you're affiliated with the drug company that's making it. And I think in the future, we'll have more adept modulation. So I think a lot of the work at UPenn is really fascinating, looking at exogenous angiotensin 1-7 or angiotensin converting enzyme 2. So sort of in combination with RAS inhibition, modulating the RAS with additional angiotensin peptides or enzymes is also another fascinating direction. And then SGLT2 inhibitors, which I realize is not a RAS blocker. And
at the moment, this is coming up a lot in our conversation.
Yeah.
It's really fascinating stuff, isn't it?
Absolutely. And I think the effects on RAS, indirect effects on RAS are currently being studied with SGLT2 inhibitors, but it is fascinating, especially with the benefit in heart failure with preserved ejection fraction in people. I think that sort of holy grail of finding something that actually helps, cats with HCM. So, and in people, the benefit with the SGLT2 inhibitors in HFpEF was independent of diabetic or non-diabetic. So I think that is a really exciting new drug, and it would be interesting to understand, better how it affects the renin-angiotensin system. So I'm kind of stealing a drug that really isn't a RAS modulator, but is super exciting, I think, in the heart failure treatment world.
Yeah, really interesting.
Can I just ask a bit of an outlier, a quick one? So ACE inhibitors in humans can cause cough as an adverse effect. And sometimes clients will ask us that if by starting an ACE inhibitor in a dog, the dog may start coughing, or if the dog is coughing, if this could be caused by the ACE inhibitor. Has anyone looked into that in dogs? Can ACE inhibitors cause cough in dogs? And is it a mechanism in humans known?
The mechanism is still unclear. In people, the sort of winning theory is reduced degradation of bradykinin and substance P, because you're blocking ACE, which degrades those things. And so you have buildup of bradykinin especially, and bradykinin then acts via stretch receptors, C fiber receptors of airway nerves, and promotes release of neurokinin A. So it generates this milieu of bronchoconstriction in people, making that sort of dry cough that some people get. But interestingly, it doesn't affect everyone equally, which is interesting. So people probably have differences in bronchoreactivity, differences in their bradykinin metabolism. So they see like racial differences, sex differences in this bradykinin-induced or theoretically bradykinin-induced cough. And why that doesn't, my opinion is it does not happen in dog or cat, cats being predisposed to, lower airway and bronchial diseases. But to my knowledge, there has been no study. So it'd be interesting to look at cats with asthma. What happens when you give them an ACE inhibitor? To my knowledge, there isn't that study in cat or dog. But I know I get that question, especially from medical professionals, that when we mention that we're initiating an ACE inhibitor, they often are like, oh, this could cause cough, and I'm going to be on the lookout for cough. And I have to admit that usually, there's anecdote in people that the presence of heart failure increases your risk of this bradykinin-induced cough, but then it's hard to know because they're in heart failure. So is the cough related to heart failure versus this actual, side effect of a drug? I personally don't think so. You always wonder when a new cough develops in an animal, especially if they don't necessarily have disease that's progressed enough to be explaining that cough. I wonder. And again, usually it's the medical professional that brings it to my attention.
Exactly.
And they're usually the ones that suggest or ask, can we please stop this as a trial? And if the cough goes away after they stopped it, I have no argument, and I basically condone discontinuation. I have not historically then, especially in preclinical disease, started an ARB, but I guess that would be an alternative. So yeah, is that what you guys, is that your feeling is not a thing potentially?
I don't think it's a thing, but I mean, who knows? Who knows?
Yeah. Yeah, the same here. It's classic. The physician that has a pet, a dog, is the one that will classically ask us that question, or people that are on ACE inhibitors and might have experienced adverse effects. But then I've never seen a case where I was convinced that the ACE inhibitor has caused cough. Tell us about your translational RAAS interest group. What is it? How can we become members? How can we know more about it?
Oh, thanks so much for asking. The translational RAAS interest group is one of the nerdiest groups in creation. We basically geek out about RAAS, and it's a group formed in 2019. Much of the impetus for the formation was from Jessica Ward, and we basically are a nonprofit group, and membership is free. We are a group of veterinary cardiologists, internists, pharmacologists, as well as some human pharmacologists and other PhD researchers in medicine. So we're a big conglomeration of people that are all interested in studying the renin-angiotensin-aldosterone system. And we basically have quarterly, meetings to help, guide our group. We have an RFP, where we have a request for proposals and fund one grant every year. And we prioritize young researchers in the area of the renin-angiotensin-aldosterone system. And we have a symposium annually. And so the best way to find information about us is the trigdocs.com website. So it's just trigdocs.com. And that's our website. Membership is free. And you can, join us for our annual symposia and just be part of a group that we bounce ideas off of each other all the time, especially when we're troubleshooting a certain RAAS assay or trying to understand, who's doing what at different universities and how can we help and cross collaborate.
That's great. We can link to the website from our episode description. So any listeners who are interested and want to check it out, they can just link direct from there. Great stuff. Thank you so much, Marisa. It's a really, really interesting area. And I think this nuance of the balance is just amazing and really offers hope for the future. The RAAS isn't dead yet. There's much more to do, isn't there? And much more that we can work on, I think, as clinicians. We have a tradition on the Animal Heartbeat of asking our guests to give their top 3 take-home messages. Now, that may be challenging, and often it is challenging because we cover quite a lot of ground over an hour. But if you can share with our listeners what your top 3 take-home messages are from the things that we've discussed, that would be fantastic.
I think the top 3 would be, we are learning more and more about angiotensin profiles. We don't yet know, what circulating profile is going to confer the best outcome. But I think the more we know, we'll be able to better inform study design and create clinical trials to actually prove outcome differences with newer RAAS modulation therapies. I would think that would be probably the most important. I would say when you're reading the literature, be aware that usually these are going to be equilibrium peptide concentrations and enzyme surrogates. So enzyme activities derived from the angiotensin peptide concentrations. These, though, have all been correlated to direct circulating assays. And so the equilibrium profiles correlate to what you would get if you would protease inhibited a sample, and the enzyme surrogates correlate to directly measured. So I think we can read them similarly, but just know that angiotensin 2 concentration is not what's actually in the bloodstream of that animal. And the third one would be that there's a really great RAAS community out there, a whole bunch of people in our TRIG group. And I think the best way to kind of learn about how you can research RAAS and join us in this mission, since RAAS is not dead, as Kieran just said, is to check out that trigdocs.com website and join us and join the search for learning more about RAAS.
Fantastic.
Thank you so much for joining us, Marisa, on the Animal Heartbeat. It's been a real pleasure talking to you and fascinating food for thought. Thanks so much.
Thank you, Jose and Kieran. I love what you're doing.
Thank you very much.
Thank you.
Cheers.
Thank you very much.